Welcome, everyone. Thank you for joining. This webinar is part of the Rungswan Research Program's Medical Education webinar series. And today our webinar is entitled Hereditary Hematologic Malignancies Are Not That Rare. And I'm Katrine Erickson. I'm the Executive Director of the Rungswan Research Program, and I'll be your MC for the webinar today. I want to first start by thanking our gold sponsor of this medical webinar, this particular webinar and others in the new year or this year, NeoGenomics. Before we jump into the agenda, I also want to briefly share a little bit about RRP. I recognize some of you may already know about RRP, but some of you may not. So for those of you, we are a nonprofit that is dedicated to supporting patients with RUNX1 familial platelet disorder. We were started by a RUNX1 family back in December of 2016, and our mission since then has been to improve the quality of life and prevent blood cancers in RUNX1 FPD. And that, of course, is given to the fact that RUNX1 FPD patients have this very high lifetime risk of developing hematologic malignancies, up to 50%. And one of the most frequent malignancy types is acute myelogenous leukemia. In addition to hosting medical education webinars and supporting our patient community, we also fund research. And so those of you who are joining us and are researchers, scientists, we have a number of grant mechanisms that are available throughout the year. And we have a number of amazing partner nonprofits that work with us to fund these projects. And so together with them, we've been able to commit over 13 million in research dollars towards understanding this disease and really discovering treatments. So you can imagine that that's why this webinar series is important to us, because understanding the underappreciation of the prevalence of germline predispositions to hematologic malignancies is really critical to our mission and to many of our sister organizations as well, like Team Telomere, Fanconi Cancer Foundation, Schwachman-Diamond Syndrome Alliance, and the list goes on. And so to all of us, we really want to be able to diagnose families as early as possible so that really preventing the onset of these heme malignancies could become a reality in the future. So for our agenda, that's a little bit about the RUNX1 Research Program, and now we can jump into the program for today. So we'll begin with a presentation by Dr. Kelly Bolton, followed by a 20-minute, 15-minute, depending, Q&A discussion with not only Dr. Bolton, but also we'll be joined by Dr. Gina Keiffer from Jefferson Medical School and Dr. Mangaonkar from the Mayo Clinic. So please feel free to pop in your questions in the Q&A icon whenever you like. You can do it throughout the presentation, and then we'll have a full list of questions to review at the end for the Q&A. All right, without further ado, I'm pleased to welcome Dr. Kelly Bolton, Assistant Professor of Medicine in the John T. Millikan Department of Medicine, Division of Oncology at the Washington University School of Medicine. Over to you, Dr. Bolton.
Yeah, thanks so much, everyone, for attending, and thanks to the organizers for inviting me. And yeah, I thought, I would speak today a little bit about some science behind, our understanding of germline predisposition to heme malignancies and management. I know in the past, a lot of the presentations have been very clinical, really focused on identifying different patients that might be at risk for hereditary hematologic malignancy syndromes. And this slide is taken from Courtney DiNardo's presentation a couple years ago. There's many different genes that have been implicated in hematologic cancer predisposition. A lot of them are relatively less common and confer very high risks of hematologic cancer. And I think we're still in the beginning of really understanding the full spectrum of genes that predispose to hematologic cancer, especially genes that might be more common and less, but with less of a high risk. And a lot of this is because of misinformation, I think, about the relevance of hereditary predisposition to heme malignancies, but also just that it can be more difficult to perform these studies in people with blood cancers. And some of the questions that I'm hoping we can discuss today, and really this is meant to provide fodder for the discussion later, is getting us to think about how we could use an understanding of germline predisposition to prevent hematologic cancers. And so I'd argue that there's 3 essential steps in this if we're just thinking about in the future how we need to conduct studies to better characterize this. First is just really understanding the genes that predispose to hematologic cancer. I showed the slide of genes that Courtney had summarized, but we still have a ways to go. The next is to understand how germline genetic variation influences hematologic cancer development, like the mechanisms of this, and to better characterize the natural history of hematologic cancer. And this will be the focus of part 1 of this presentation. And then in part 2, I'll briefly touch upon how we could use this information to help develop tailored management strategies for germline carriers. So in order to think about how we can use an understanding of germline predisposition to change outcomes in people with heme cancer, I think first we have to remind ourselves that fundamentally cancer is caused by a cell acquiring multiple mutations that occur in successive order over time, and eventually lead the cell to behave abnormally and to become a leukemia stem cell. But we know that from large population-based sequencing studies in healthy people, that you can really detect this process, this stepwise acquisition of mutations in the general population very easily. With age, we acquire mutations in all of our tissues, including stem cells in these normal tissues. And one of the maybe unsurprising things is that the types of genes that you see mutated in different organs are the same genes largely that cause cancer in those organs. And this is because, again, the mutations that lead a stem cell to proliferate are likely the ones that would then eventually lead to cancer. And this is really the best characterized in the blood because blood is so easy to sample. And this is a huge advantage for the germline field in heme malignancies. So we know that when hematopoietic stem cells acquire somatic mutations in certain genes, it can lead to that stem cell gaining a fitness advantage and proliferating more than wild type cells. And this is called clonal hematopoiesis, or CH. So just like mutations in other tissues, this is very common with aging. But importantly, people that have clonal hematopoiesis are at an increased risk of hematologic cancer. But one of the tricky things in terms of if you think about trying to intervene in CH is that actually as we sequence deeper, we actually find that basically everyone has CH by the time, especially by the time you reach middle age, and actually most people have multiple mutations in their bone marrow. So mutation acquisition doesn't seem to be the rate limiting step in people getting cancer. It must be something else, not just the acquisition of mutations. And one thing that we've noticed, and this has been characterized in multiple different settings, is that different CH mutations have different risks of hematologic cancer. So genes like TP53 or IDH confer very high risk of cancer, and genes like DNMT3A or TET2 confer much lower risks. And this has been shown in multiple different populations in multiple different studies. So what are the factors, like why essentially do genes in different genes confer different risks of cancer in people with CH? And it's because those genes have different effects on fitness. And so what am I talking about when I talk about fitness with clonal hematopoiesis? So it's this concept that in a in a person that has a mutation, a CH mutation in a gene that confers a low fitness, that mutation might slowly grow over the lifetime of an individual, whereas a gene that confers a high fitness will rapidly expand and maybe even attain dominance in adulthood and has a much higher likelihood of eventually leading to cancer. So this has been shown in prospective studies where they've done longitudinal sampling in the blood of healthy people, that the same genes in general that confer the highest risk of heme cancer are those that grow the fastest over time. So this concept that really fitness is the key feature here in predicting risk of cancer progression holds true. So, but what you might be asking, hey, she's gone on this huge sidebar about clonal hematopoiesis. So what does this have to do with germline genetic variation? So the reason that I bring it up is really because there's two potential ways that germline genetic variation could lead to hematologic cancer. So one is this idea that it could influence CH initiation. So maybe the rate of mutations or the age at which mutations arise. But the other big broad sweep would be influencing mutational fitness. And I argue that I think a lot of the data supports this idea that germline genetic variation, the primary way that it causes cancer is by modifying CH fitness. And so this has been shown in multiple different studies in less common high penetrance hematologic predisposition genes, including work by Abhishek, who's you'll hear from during the panel. But we know that different germline mutation carriers have get CH at very young ages, that they have these clonal expanded clones at very young ages, which is very rare. It's very, very rare in the general population to see. And they have mutations in really specific genes. So it might not be the same typical CH genes you see in a middle-aged individual, DNMT3A, TET2. It's specific genes. So for Elaine, for example, you see a lot of CSF3R mutations, RUNX1, you see B-core mutations, among others. And the thought is that why this is happening is because these germline mutations modify the risk or the rate of progression of CH in specific genes because of interactions between the somatic and the germline. But what about in the general population? Like we know that germline genetic variation leads to heme malignancy, and we know that germline genetic variation influences CH, and we know this from GWAS studies. But how and to what extent do the same germline genetic variants that influence CH lead to heme malignancies? And can we use this to better characterize germline predisposition to heme malignancies? And I argue, yes, I think this will be an emerging field and will help clarify more hematologic predisposition genes. And so we took a stab at this as a first approach in the UK Biobank and other large population databases. So, and this work will be out in Nature Genetics in the next couple weeks. So the first goal of our study, which I bring up because I think it does add some clarity about the frequency of germline genetic predisposition to heme malignancies in the general population. So our first goal was to just identify additional genes that predispose to CH and heme malignancies, and to use this to better understand why certain people with germline genetic predisposition genes develop heme malignancies and others don't. So we did this, like I was mentioning before, in the UK Biobank, which is a wonderful resource for people doing studies in heme malignancy or CH. It's a population-based cohort of healthy middle-aged people. In the UK, there's a good amount of follow-up data now, and about 5,000 people in this cohort have developed heme malignancies. And we use several other databases for validation of our findings. So we focused in this paper on less common pathogenic germline variants in known hematologic predisposition genes because we really wanted to focus on people who had genetic variants that we were more confident about were actually impacting the function of the gene in question. So we found that a large proportion of people harbor a pathogenic variant in a germline predisposition gene for cancer. It's actually about 9%. And the most common two genes, CHEK2 and ATM, were present in about 1.5% of people. So very common to have a cancer predisposition gene in a healthy population. And CH was also relatively common. We're detecting CH here using whole exome sequencing. So we're only able to detect clones that have expanded quite a bit, which is why the proportion of CH is, on the lower side compared to maybe other studies that use targeted sequencing platforms with higher depth. So we wanted to understand, which of these genes or does having a pathogenic variant in a germline predisposition gene for cancer influence the frequency of CH? And we saw that it does, especially for CH driven by copy number events, which I'm abbreviating as MCAs here. And next, we wanted to understand, and characterize which genes were driving this increased prevalence of CH among germline carriers. And we found 15 genes that were associated with CH overall, both for copy number CH events and for SNVs and indels. And so you'll notice that a lot of these genes were in Courtney's previous slide of known hematologic predisposition genes, but there's a few that are less well established. CHEK2, like I mentioned before, present in 1% of the general population, conferring a twofold increased risk of CH. ATM, present in 0.5% of the UK Biobank. MIPL, ACB11, which is a gene involved in hepatic metabolism, and CTC1 and BN. These are genes that predispose to heme malignancy in the autosomal recessive setting, but here we're seeing that people with just one deleterious variant have an increased, a modest increased prevalence of CH. So, like I was mentioning before, in people with rare, with less common, Mendelian syndromes, we see that they get very distinct types of CH, likely reflecting fitness pressures. So does that hold true here in more common genes like CHEK2 and ATM? And so we answered this question by just doing pairwise associations between different germline genes and different genes that were acquired, CH genes that were acquired in the somatic setting. And so we saw that, yes, we just like, people see in less common Mendelian predisposition, even in genes like CHEK2 and ATM, you see that certain genes, for example, CHEK2 predisposes to an increased risk of DNMT3A and TET2, but actually seems protective against TP53-CH, whereas ATM seems like it's the most strongly associated with JAK2 and with actually a somatic ATM, so probably reflecting a biallelic loss of ATM in these individuals. So if this is driven by selection pressures, then you might say, well, maybe you would see even more associations between germline genetic variants and CH if you look at CH in terms of predisposition to specific genes. So we did this, and we, in the end, identified 55 additional genes that predispose to CH driven by specific somatic events. So overall, this seems to suggest that a lot of germline predisposition to CH is gene specific and probably driven by different influencing the fitness of these somatic events. So if that's true, then we should see that a lot of these genes also increase risk of hematologic cancer, and we did. So a lot of these, like I mentioned before, are known to cause hematologic cancer. Some are less well established, but in the UK Biobank, in this big population, I think we provide very good evidence that they do at least moderately increase the risk of hematologic cancer. And through this, we also identified 4 potential novel hematologic cancer predisposition genes that that we need to validate in additional studies, but are promising leads. So in summary, I found 15 genes that predispose to CH. They were predisposed to specific CH subtypes. And a lot of these genes also increase risk of hematologic cancer, which makes sense since CH is the precursor of hematologic cancer. But, how could this help us to better understand how CH and germline genetic variation interact to develop hematologic malignancies in some individuals? So there's different ways of looking at this. First we just asked, well, if you have a germline predisposition to hematologic cancer, does that interact with CH in influencing your risk of cancer? So we compared the risk of people with a germline predisposition gene only and no CH, people that had CH and no hematologic predisposition, germline predisposition, and people with both. And you can see that there's clearly a multiplicative interaction between having a germline genetic variant that predisposes to hematologic cancer and CH in predicting risk of progression. And that risk varies by germline gene. So genes like KRAS or TP53 or RUNX1, if you have CH, you have very, very high risk of developing hematologic cancer. If you have ATM, or CHEK2, it confers more modest risks. But interestingly, the fact that you can use CH to risk stratify individuals with hematologic cancer is seen really for most of the germline predisposition genes. So here I'm showing the risk of cancer among people with ETV, RUNX1, all the more common germline predisposition genes for heme cancer. And for some genes, we actually found, like for TP53, that people without CH had basically no risk of hematologic cancer, whereas people with CH had very, very high risks. So, if germline genetic variation is modifying CH fitness, then could we leverage that to better understand and better characterize who has high-risk CH versus low-risk CH? So like I mentioned previously, we know from studies in the general population that TP53 or IDH1 and 2 are generally considered high-risk CH mutations, whereas DNMT3A or TET2 are considered low-risk mutations. But I showed you previously that, for example, people with CHEK2 germline genetic predisposition, they're more likely to have DNMT3A CH and TET2 CH, but actually less likely to have TP53 CH. So could it be that in a CHEK2 carrier, for example, that's TP53 is actually a low-risk CH gene? And so we answered this question by taking all of our germline carriers and classifying their CH mutations into genes that had evidence of selection. So we saw modest or strong associations between CH and that gene and germline genetic variation. And other CHs, basically, there were CH in genes that showed no evidence of being enriched in the germline carriers. And so we, just reminding you that, for example, in a CHEK2 carrier, DNMT3A and TET2 CH would be germline selected CH, whereas TP53 CH would be other CH or non-selected CH. And so we saw that in general, yes, this idea that genes that were selected for with a certain germline genetic backdrop conferred a much higher risk than CH in genes that were not enriched in germline carriers. And this wasn't driven by specific germline carriers. It was really seen across different carriers for both lymphoid and myeloid malignancies. And we even saw this, zooming in on CHEK2 carriers, our most common carriers, and DNMT3A-CH, our most common CH gene. We saw that if you had DNMT3A-CH and you had a germline CHEK2 variant, pathogenic variant, your risk of getting heme malignancy was much stronger than if you didn't have that germline CHEK2 variant. So again, just I think further providing evidence that even in the general population, the way that germline genetic variation is influencing hematologic cancer risk is through CH largely. So I think this is, notable because, we found in the UK Biobank that actually 5% of healthy people have a germline predisposition gene for heme malignancies, and that represented 15% of people who developed heme malignancies. So this is a very common phenomena. CH can be used to risk stratify progression to heme carriers, to heme malignancy among germline carriers. And the CH genes that we consider high versus low risk vary by germline genetic makeup. So this implies that, that there is really important risk stratification to be gained by doing larger scale germline screening for heme malignancy. So how can we use, this understanding that from this work, but, really from mountains of other work that have helped us to understand the genes that predispose to heme cancer and the natural history of this. And really, of course, the end goal is to develop tailored management strategies for germline carriers. We're really in the very early stages of understanding this. And a lot of this has been, done by my colleagues, including people on the call today, about, trying to understand how we can do this. And, maybe our first step is to try to figure out like who should be screened. And so there's this, I think, and I'll argue that I think all people with hematologic cancer should be screened for germline predisposition. The reason why is because, 15%, at least 15% of patients with heme cancer will have a germline predisposition gene. And this number keeps on growing. Every year, probably it will continue to increase. And germline genetic testing is really cheap. And it's a cost-effective means of identifying an at-risk population. And we know that a lot of the germline heme predisposition genes, especially the common ones like CHEK2 and ATM, they also increase the risk for solid tumors. So that has implications both for the proband and also for the family in terms of their screening for other cancers, even beyond hematologic cancers. And for our patients with heme malignancy, germline predisposition seems like it influences outcomes. And definitely probably the best data for this is in regards to transplant decision making. So it can have implications for the clinical care of our patients. So for example, this is taken from Courtney again. For patients with inherited bone marrow failure syndromes, we know that we have to use reduced intensity regimens. For DDX41 carriers, they seem like they have actually a good prognosis. There's some data that they might be sensitive to lenalidomide, but really we're the best. We have the best data is in terms of just management of transplant decision making among germline carriers. So we know that donor-derived leukemia can happen after transplant. And this seems to be especially prevalent in germline carriers, especially DDX41 carriers, just because this is a very common gene in individuals with M.B.B.S. There's been several case reports on this. I'd say the best or the largest scale so far published work on this in carriers, looking at carrier status and outcomes in transplants, comes from work by Chris Gibson, where they identified that several individuals who go on to develop donor-derived leukemia had DDX41 mutations. In this cohort out of 17,000 people, there were a handful of individuals who developed donor-derived leukemia, and actually 2 of them had germline DDX41 mutation. So clearly this is a risk factor for developing donor-derived leukemia. And so in anyone who you suspect that might have a germline predisposition to hematologic malignancy, you would want to screen any relatives for that mutation after first testing your proband to make sure that you're not transplanting someone whose marrow is already predisposed to hematologic cancer. So, but so we have data from the transplant setting and some data that, we might need to tailor our risk management for germline carriers, but you might say, well, this really only, the best data only comes from transplant outcomes. And, maybe you only really need to do this in the setting of transplant or when you have a very high suspicion for hematologic cancer. And that might suggest that, we shouldn't screen all patients. Another argument is that, when you screen a patient for hereditary hemalignancy, then it has an influence not just on them, but on their family. And we don't have any interventions right now for asymptomatic germline carriers outside of clinical trials. And so this could cause, stress for some patients. I would argue that just becomes an issue of needing to really counsel patients before we test for germline predisposition so that they understand the implications, both for their, management right now and for the future, and give people the choice about, not getting testing if they feel that this is going to be a big issue for them and will cause more harm than good. But, looking forward to the future, we don't have that many interventions right now, especially none outside of clinical trials, really. But how, when we're thinking about developing an intervention for germline genetic variant carriers, what would this be? And so I think that it's pretty clear that it would have to be is we would have to modify the fitness of CH in germline carriers in order to ultimately prevent them from developing hematologic cancer. So there's kind of a few different ways of thinking about this. One would be to target the specific mutation, like, for example, in RUNX1 patients, to target ASXL1 or BCOR, which we think are enriched in these people and higher risk potentially of causing heme malignancy. Or another example might be, where we have a really good targeted therapy would be, ivosidenib for IDH1-CH. So the advantage of that is that, if you had a really good targeted therapy, theoretically, it wouldn't have very many off-target effects, and so would be well tolerated. People could take it over a long period of time. The downside, of course, is that by targeting one clone, you could just lead to the emergence of a different clone and really not influence ultimately the likelihood of them getting cancer. Another potential approach would be to target a pathway important in progression of CH in that germline carrier, like inflammation or something else. The advantage would be that you could potentially prevent multiple clones from expanding and leading to cancer. But presumably there would be more side effects. And we really don't have good examples, honestly, of candidate drugs that would meet this label right now. So we still have a ways to go, just actually in even terms of having drugs that we could use for this approach. But I do think it's very promising. And I think the best data for this idea of intervening early comes from clinical trials of people with CCUS. So these are people that have CH plus low blood counts. And the vast majority of them go on to develop heme malignancy. So they're a very high-risk population, much like some of our germline genetic carriers. And there's a lot of clinical trials right now in individuals with CCUS trying to intervene early. One such example of this is some work that we're doing in IDH1 and 2 mutant CCUS. This is a rare patient population. It's actually only about 1 to 2% of people with CCUS. But the reason why we're interested in it is because IDH1 and 2 have great targeted therapies, ivosidenib and enasidenib. They have good response rates in myeloid malignancies, like 40%, but everyone relapses eventually. And we know that for these targeted therapies, that people that have lower mutational burdens respond better. So it would make sense that if you give it to people that have CH or CCUS, the response rate should be better. So we have a trial in this. Our goal initially was 15 patients. We've actually expanded to 20. We still have open slots if anyone is interested. in both the IDH1 and the IDH2 studies. And our main question was just, is there activity of ivosidenib in CCUS? Like, can we resolve these cytopenias? And so the data is really great from this trial. So actually, overall, we've seen 81% of patients have a hematologic response. So the vast majority respond. Most people are still on study, and they still have a great response. We've seen in almost all of the individuals normalization of their blood counts. Even over a year now of follow-up, still, like most patients have complete normalization of their cytopenias. And we even see that we're decreasing the mutation burden of the IDH1 mutation over time in most patients. So, I think this approach is very promising. I think this is going to be the future for trials in germline predisposition, targeting CH early and trying to modify the fitness of CH. And so, understanding the natural history of this is just so critical in order to make this work. And I think, we already have great examples of this in CCUS, and we're going to have more studies in germline carriers in the future. And I'm very hopeful that this is going to really revolutionize our care of these patients. So I want to thank just my lab, just really briefly, just Jie Liu, who did the work that I showed previously on germline predisposition to CH, and my funders, and to the Runk Fund Foundation for being such a great educational and research foundation in this important field. So thank you.
Thank you so much, Dr. Bolton. That was a really beautiful talk. I loved how you took us through, the prevalence and all the data that you've generated from the UK Biobank, and then also ending with really some fantastic hope. And it's great to see that IVO data, 81% response. That's awesome. Okay, I see that there are some questions in the Q&A. Please go ahead and put your questions in, and we can have a nice discussion. We are ready to begin our panel discussion, and so I'd like to welcome Drs. Keiffer and Mangaonkar to our virtual panel here. Dr. Keiffer is an assistant professor of medical oncology at Thomas Jefferson, and Dr. Mangaonkar is an assistant professor of medicine in the Division of Hematology at the Mayo Clinic. Welcome to you both. We did get a question about donor-derived leukemia and the need for testing for germline predispositions in donors. But then the response was, "Oh, I saw your slides." So I'm like, I don't have the question anymore. But I thought maybe we could just pause there for a second and talk about what is happening in practice, and how often are transplanters thinking about germline predisposition, and how often are they actually testing donors? Is it really specific to whether there's been an identified germline predisposition in the individual with hematologic malignancy, or is there sometimes cases where a donor might be sequenced for another reason?
Maybe, I don't know, maybe Gina or Abhishek might want to have a chance to.
Yeah, please go ahead.
Yeah.
I think from our side at Mayo Clinic, we actually we have a clinic where we assess donors, at least related donors for this, and especially if there is a history of heme malignancies in the family, or even if we can't detect the germline variant in the patient, sometimes we try to take a broader approach. We at this time we don't have the we don't obviously test unrelated donors, and I think that's a question that we have. Like, should we be testing given the high prevalence of some of these germline variants? I think we're not there yet, but I think for related donors, we try to test quite a bit of those, especially if the age of onset of malignancy is, say, less than 40 or in the younger age. So that's what we do here.
Yeah, I think this is an area where there's a lot of variability between centers, to be honest. And I think, this maybe touches on one of the other questions about you know, how frequently patients and donors are being screened. But I think there's definitely room for improvement across the board in terms of how many patients are being referred and sort of the understanding on the part of the providers of you know, who needs testing. As Kelly was saying, you know, year on year, we're seeing this become more common. And so I think there's a sort of historical perception in the field that maybe these things are more rare than we are learning them to be. And I think that's maybe one of the bigger barriers. But I agree with what was said in terms of the others, that that is really important, particularly for, you know, if the patient has a suspected germline predisposition. But I agree with Kelly's argument that really, I think we should be doing this across the board. And I don't think I mean, that's certainly not happening everywhere.
Yeah, there was, I mean, this is related to another question that came through referencing the NCCN guidelines and the fact that adult patients with MDS and AML, it's recommended that they undergo germline genetic testing, full stop. So I believe this is coming from a cancer genetic counselor, and she's saying, I don't seem to be getting all these referrals, and I'm curious why that is. Do any of you have any insights you want to share about that and how we might be able to change that behavior? A tough one. No.
Yeah.
I think it is a tough one. I think some of it is recognition on the part of providers. I'd be curious to know the percentage of hematologists and medical oncologists who are aware of that recommendation. I think there's a lot of room in education in terms of simply being aware so that referrals can be made. And I think but there's other factors too. Logistically, many of these patients, particularly the acute leukemia patients, are quite sick at diagnosis. It's not always possible to do this testing on an inpatient setting, although I think that's something as a field we should work towards improving. You know, testing the skin in the setting of an active diagnosis can also be a barrier. Not all institutions are set up to do that easily, or you know, so I think there's a number of steps. I'm curious what other people have encountered, but
Yeah, I agree with that. I think that education is important, and I mean, with the frequency being as high, somewhere between 10 and 20%, I think that I agree with Dr. Bolton's comment too. Like, we should be testing everyone. One barrier that we face here is in terms of genetics is just access. You know, if the appointments are going out too far out, or you know, that really there's no. We sometimes hematologists or oncologists feel that it's not really going to change the management. The second point is the insistence on testing on germline tissue initially. I'm not sure if we should do that. We should be a bit more liberal with at least doing the panels initially on blood, and then try to sort out what is somatic, and then do the next step as germline validation if we find something, because often that becomes a barrier as well. So yeah.
Yeah, I actually really agree with that, Abhishek. Like, I think that's we're so focused sometimes on making sure we get the gold standard germline testing that we basically miss huge proportions of patients because we're so fixated on that. I personally recommend that people just do a germline testing in the blood first. And then, you know, if you find something, then of course, then you have to confirm it later. But there's multiple ways of doing that, by testing relatives, by testing the patient. But you know, ultimately, like, if we can just, I think, loosen our restrictions and just kind of do what's feasible for our patients, then I think that would be better. You know, if we could, because we do mutation testing in the blood routinely for somatic purposes, and so to just add that on as a germline test would be great. As you know, And, you know, the germline testing itself is very, very cheap, even if it's not covered by insurance. Like Invitae has a panel. There's, you know, multiple companies that have panels where they have really good patient assistance programs. So I think yeah.
Is there a panel, like if you were to do, when you do your molecular profiling or somatic profiling, is there a panel that sort of covers both the somatic mutations of interest, but also includes the germline, or would you end up ordering two panels essentially?
At least at our institution, our somatic panel doesn't cover like intronic regions well enough. And so I order a separate panel. It would be much more cost efficient if, you know, there's ways, you know, yeah, of kind of combining the two together. But yeah, right now I order a separate panel.
On the blood, okay.
Yeah, from the
And then
blood.
what do you use as your cutoff for, shoot, this VAF is kind of high? Because it could be, I mean, do you go as low as like 30% or 35 and say, uh-oh, this could be germline? Or are you more strict with, do you say like between 40 and 60 for an autosomal, I guess that it would be?
Well, so for we don't have a germline panel at WashU like in-house. So
Uh-huh.
I use Invitae
Yeah.
and commonly, and you know they're not going to report mutations at low VAF.
Okay.
So you know that's the downside. For the somatic space, you know, we've seen, depending on the depth, we have a very deep targeted panel. You can see germline variants, you know, as low as like 25% VAF even sometimes, because there can be certain regions of the genome that are just technically there's bias in the VAF. Even if it's germline, it's like biased systematically towards being lower. So, you know, you can have, I think, down to 25% would be.
Oh, wow. Okay. So that would be enough for you to say, May, let's do a germline now, like real germline tissue,
Yeah.
if you saw that.
Yeah.
There was one comment in regards to this topic about, well, if you have a hemalignancy patient, you're worried about, you know, having to get grow out fibroblasts. Could one approach be to test unaffected relatives as a way to get at the germline testing?
So unaffected in the sense, yeah. I mean,
It's challenging, right? Because if you don't have a family history, or if it's
right.
sort of
It's somewhat helpful, yes. But yeah, ideally we would want like an affected and unaffected member of the family, and you know, sometimes that's just not possible. And so yeah, I mean, we do that routinely too. I mean, I think we first start with so our Mayo panel has some predisposition genes, but again, it's not comprehensive. So we do send separate panels as well, and then we try to then, if someone is positive, then we try to sort it out through germline validation, and then test the family members. And that's one supportive evidence. And in some cases, we have the capability to do some additional testing downstream on the functional side. But yeah, it's always helpful to start with a screening platform first and then try to zero it down.
great. Thank you. There's a question, and maybe you all on the panel can help me figure this one out. So it says, do the specific mutations in an exon are they more relevant for both creating CH versus hemalignancy? I guess maybe the question is really specific to the variant type, or what are your thoughts on that?
Yeah, I mean, there's for somatic variants, for example, like in DNMT3A, the R882 hotspot, which probably it is like a dominant negative mutation, confers a higher risk of leukemia than other mutations, like, you know, nonsense mutations or other missense mutations in DNMT3A. So there's definitely examples of that. I think we're the best powered to study that with DNMT3A because it's the most common gene, but for sure. I mean, I think that'll be more studied in the future for other genes.
Okay, we have another question here. I think getting to somatic mosaicism or somatic reversion. Do we know the risk of reversion back to wild type? So thinking about negative tests on blood samples. Do we have data on that? And is it more maybe germline predisposition specific, or what is the rate?
I think it's gene specific. There's data on some genes that it does, like the Fanconi genes. There's evidence that that happens. And maybe there's some for the telomere genes. There's some evidence that that happens too. But yeah, I mean, that's a valid point. So I think when you test some of these, you have to take it with a grain of salt. And obviously the gold standard is germline testing. Now there's also some challenges, especially with certain genes like TP53 and with some of the telomere genes, like the skin fibroblasts, for example, don't grow in germline telomere genes. Like if you have a germline mutation there, sometimes that fails, and then you have to test something else, like we do the hair DNA here and some other germline testing. So, and some of the TP53 cases, they could be actually negative in the skin fibroblast, but be positive in some other germline tissue. So there are some nuances like that with particular genes that we should take into account.
It's still not a reason not to test, right?
Oh yeah, yeah,
There's
definitely.
a question, sort of a logistic question, but I think it makes sense in this discussion about, whether or not to just quickly test the blood, even in a hemalignancy patient, just to get a sense of whether you see any germline variants. And that is, will these labs actually accept blood with someone who has a known hematologic malignancy? Have you had any issues there, any of you?
I haven't had issues. I don't know if Gina or Abhishek have. One thing I have had, if you sometimes like I'll try, I've had situations where I have somebody who's post-transplant and they are referred to me for germline testing, and but they don't want to do a skin punch, or they have financial reasons or whatever. And so I've tried in the past to do a buccal swab, like to really rinse out their mouth and do a buccal swab and send that to a commercial lab, and it's never worked because there's just too much mosaicism, and the lab will just, they say the sample failed. So that's the only I guess time that I've run into big technical problems. Have you guys had problems with that?
Yeah, I've had some issues. I mean, mostly no, but sometimes yes. If it's a leukemia patient, they won't accept blood, and that can be a bit of a challenge.
When you're testing for a germline, yeah.
Yeah, yeah, and yeah, maybe that, and sometimes we want, like, if there's a clear family history and the patient's young and we want to take to transplant, we want to move quickly, and skin testing may not be, the fibroblast culture may take a while. So that we try to, sort of talk to the lab and try to explain them. It's, yeah, sometimes we face issues with that.
I have heard that there are some protocols about using nails, and that those are getting better. Have you heard that you've been able to get better DNA extraction from nail clippings, for example?
We are piloting hair follicles.
Hair.
It's very easy to get in the DNA. We just take like 15, 20 hair, clip the hair bulb, and use the DNA from that. That's very, and most patients, we have access to that. And I think the DNA quality is fairly good. You can do, even like, we primarily use it for like just validation. Like if you want to test a single gene, like for example, we use it for that, not for like the whole panel. But I think that the DNA quality is enough to also do the whole panel there. We're not there yet, but I think that's one of our preferred sources. I'm not sure about nail, but We don't have experience using that here.
It seems we've hit upon a very hot topic because there's a lot of questions about, how logistically, even with insurance coverage, can you get genetic testing twice for an individual if you first send blood and then you try to go back and do germline. I think, I mean, you can all speak up here, but my hunch is that this is just more of a discussion of creative solutions. If you don't have time to do a fibroblast, this is something to do. I think you probably would all say like the gold standard still is the gold standard. If you can do fibroblast, then that should be done. But I think sometimes you just don't have that option. And I think those were examples of how to get it done quickly. I really wanted to have a discussion about timing of intervention because I think some of the data that you showed, Kelly, on really the high risk of hematologic malignancy in individuals with germline predispositions who have CH. I'm just so curious about how you're thinking about the timing of intervention, and I'm gonna raise the what comes up in our community a lot is preemptive transplant at this point, knowing that we don't have anything yet. Hopefully very soon with clinical trials, we'll have things like IVO and others where we can target specific clones or anti-inflammatories. But how do you think about preemptive transplant in some of these more very high risk cases?
Yeah, I mean, I think so. As transplant is like the conditioning regimens for transplant are becoming better and better. There's a lot of really great research, I should say, maybe about like novel ways of conditioning for transplant that are less toxic, and then different ways of reducing risk of GVHD, like graft versus host disease. Yeah. So transplant itself is getting more and more safe, and you could argue that in someone who's getting maybe in the future you could envision someone with RUNX1 who has CH at a certain, once they hit a certain level and we know it's a high risk gene, maybe we would transplant them, but maybe we'd be able to use a regimen that's not toxic to avoid those long-term adverse health outcomes. I think that's very promising. In addition to this idea of targeted therapies. I think it's very promising. Maybe not right now as much, but there's so much work being done in this area.
Yeah. And I just would imagine that, you started off the conversation saying, there's usually at the time of leukemia, you've got 4 to 6 mutations.
Yep.
You've got an individual with RUNX1 or pick your germline predisposition gene that has now acquired 2 or 3 somatic mutations. They still don't have necessarily MDS or AML, but the clones are growing. You could imagine a place of feeling like perhaps there's a time very soon that something should be done.
Yeah. And I mean, they're also, presumably their marrow, it would be easier to ablate their marrow, right? In addition to using a targeted therapy, they're less resistant. So your conditioning could be lower. Yeah.
Did you want to say something, Dr. Keiffer?
Oh, no, I was just sort of going to agree with what was being said. I think there's we all know that these patients are fine until they're not. And so, when exactly to pull the trigger, hopefully we can have, and I know there's a lot of research dedicated to sort of defining when that might be, but I think it's appealing as providers, and I think it's appealing for patients too, who, particularly those who've seen their loved ones, die from these diseases or have complications from chemotherapy or whatever the case may be. So yeah, I agree. I don't think we're there yet, but I think it's sort of top of mind for many in the field.
Yeah, thank you for that. There were some questions about VUS. I realize we're a minute after the end of this webinar, but I just wanted to throw out that, some people are worried about these VUSs. is there anything that you all want to share? I mean, I know hopefully people are aware of ClinVar, and you can go into ClinVar and evaluate whether the any of the expert curation panels have actually, reclassified something. But I think most of the commercial labs are pretty close to use ClinVar when they report. Is there anything else that you would recommend in terms of the challenge of VUSs and what to do?
I usually just recommend, like, I get questions like this all the time. Can you look at this VUS? Can you look at this VUS? And I do look at them, but I'll usually say it's a VUS. And if it changes, you're gonna hear about it.
Yeah.
So, but that emphasizes this idea that in addition to like talking to providers about like educating them about what a VUS is,
Mm-hmm.
and that for the most part, if they're downgraded, not upgraded, you also have to have that conversation with the patient before. So
Yeah.
that's why you need genetic counselors or just a provider that's educated about this to preemptively talk to the patient about, especially for heme malignancies, these genes are not well characterized. So they report a lot of VUSs.
Mm-hmm.
It's not like BRCA1 where the VUSs have been like, really well studied and like sorted out.
Mhm.
So you're likely going to get them, but likely they're meaningless.
Until they're not.
Until they're not.
Yeah, I do worry about that. I was going to bring up the same point comparing to BRCA, where we have such well characterization of the variants and those genes. I think counseling is super important because the likelihood that it gets upgraded is probably not quite as low as it is for other genes that we understand a lot better. And so patients need to be made aware of that in advance so that it is a little bit easier as you're discussing it on the back end and reinforcing the importance of, continued, that patients need to be updated when there are changes in these genes, and that too may change over time.
Great. Yeah, it's education is so important and why we're here today. But thank you. Thank you both, or all three of you, for being here today, and especially thank you to you, Kelly, Dr. Bolton, for such a great presentation. It was very thought-provoking, and I think everyone really enjoyed it. And there are some questions we didn't get to, so I might try to collate them and see if we can get some responses via email, and then we'll send out the recording and then some of those unanswered questions, perhaps some answers. So thank you. Enjoy the rest of your day, and see you at the next webinar. Take care.